Welcome back, everybody. Today we are back with Dr. Dean, and we were going to talk about the angiotensin-renin system and kind of see where that lands us with bodybuilding. What's going on, Doctor? How you doing?
It's great. It's great to be back, Kurt. I know we planned this before Christmas. I think it was the last chat. So yeah. I was very excited to get back on after we had that really nice reception to the video on clenbuterol. I think that opened up a few minds surrounding the lipolysis versus the fatty acid oxidation discussion. So I was really looking forward to getting into something a little bit more gray, I think, now in terms of other medications in the field of bodybuilding.
Yeah. Well, and I know the clenbuterol discussion changed my outlook on the use of it, and beta-3 receptors and stuff. So let's talk about ROS. So what's going on here? We see a lot of interesting stuff going on with androgens and prophylactic use of blood pressure medicine.
Yeah, I think this is one thing that I get pulled into now, sort of online. Me personally, that I'm against like blood pressure medication. So for the record here, I'm never against blood pressure medication. But my view is every medication has a purpose, and we utilize that pharmacology for a specific purpose. So when we look at blood pressure, we've got a few different things going on in terms of blood pressure. We've got vasoconstriction, where the actual arteries themselves have closed in. We've got expanded extracellular volume. So we've got too much extracellular volume now that the heart has to facilitate to handle that extra pressure, pressing out against the arteries. We have higher blood viscosity that we can get into, where the RBCs now have taken over a higher percentage of the serum. You've got electrolyte imbalance that plays into the extracellular volume as a sort of adjunct. And then after you sort of work your way through all of that, you arrive at the ROS system and the production of renin, aldosterone, and angiotensin.
Yep. So with the first part, we could probably talk about growth hormone and extra fluid, right? That's
yeah. I mean, the thing that when you look at growth hormone and how it gives us a really nice visual appearance, I was only having this discussion with someone the other day, is on like a biochemical level, it actually suppresses your antidiuretic hormone vasopressin. So you end up retaining more extracellular fluid, but you also end up holding more sodium in that extracellular fluid as well. So that's where you get that really nice, and I personally have gotten it, that bubbly, round, full look from it because of that retention. But because of that, now you've basically occupied more space within that arterial wall, as to speak, and that increase in pressure, increase in volume has to be accommodated by the heart to effectively push everything around. So you can see, probably 10, 15 point shifts in your blood pressure if your cellular hydration isn't optimal for that electrolyte balance.
Yeah.
And we were only talking about that in terms of like, there's so many things that interact with your extracellular volume in terms of your electrolytes. So on a real simple level, sodium will keep water in the extracellular space and potassium will push it intracellularly. So it's very important that we have a good balance where we're actually storing water inside the cells that need them to live and having enough in the extracellular space that's being transported around the body.
Correct.
And that goes down to making sure that your potassium content of your diet actually outweighs your sodium intake.
Now, with that, I was just going to ask, how often it's very trendy now for people in social media to recommend that average people drink salt water. I've not personally seen a whole lot of people that are sodium deficient in the United States, at least. I'm not sure what goes on in Europe, but I can't imagine that being sodium deficient is really much of a thing.
No, not in my view anyway, considering like processed foods. I guess not even processed foods. If you're having takeaway foods or restaurant foods, there's going to be a ton of sodium, added sodium, that when you really look at someone's potassium intake, in order to like the RDA for potassium, last time I checked, was 4,700 milligrams. So it is huge. And in order to be like a 2:1 ratio for your sodium to potassium, you're looking at your sodium being about 2,000 to 2,500 milligrams, which isn't a lot.
Yeah, you would
It's
take a
about
massive amount of potassium to balance the average person's sodium intake.
sodium. And so when you look at like what are potassium rich foods, okay, you've got like your typical vertical diet foods of, you know, potatoes, some level of sort of nuts, a couple of different vegetables, but very difficult to get up to that 4,000 without perhaps using something like what we have in Europe called low salt, which is a potassium chloride table salt. So you're effectively substituting sodium chloride for potassium chloride, but you're putting that electrolyte that your body needs in high amount to compensate for the sodium intake. And so if that electrolyte balance is off, first and foremost, there's going to be more fluid in your extracellular space because of the higher sodium. And another symptom of that sort of excessive sodium intake tends to be nocturia, where guys are going to the bathroom at night because during the day there's a lot more fluid in the extracellular space. It can pool, you know, on their legs and their ankles against gravity. And then at nighttime when they're lying down, blood pressure comes down, obviously, because you're lying down flat, and that fluid returns to the kidneys. You have to keep going to the bathroom because of your excreting out this excessive sodium.
Yep. Now, and another interesting thing that we see here is in the United States, I think 83 or 84% of Americans are deficient in iodine, right? Because I think with this trend to increase their salt intake, erroneously, they're also using things like sea salt, which, right, on the surface, I think seems healthier, but yet it's creating possibly a worse problem.
Yeah, like when we look, a lot of mineral deficiency occurs within the world, and it's got to do obviously with the soil. The soil is changing over time. We've got less selenium, less zinc, less magnesium. So the foods that are growing in that soil are going to be slightly devoid of those nutrients. So yeah, like iodine. I remember there was a big push on iodine here in Europe, maybe 5 or 10 years ago, to make sure that you were staying on top of it. And obviously that plays into thyroid as a whole other avenue. But,
and I brought it up also because I've seen it recently in lab work with someone on growth hormone, and their thyroid levels were off. They were actually taking sodium, but they were actually tested for iodine. Their iodine was low, so you could actually see that it was screwing up their thyroid, and the growth hormone was making it worse.
Yeah, and then obviously growth hormone playing into TSH and telling the thyroid try and make more, and the thyroid hasn't even got the building block.
Yep.
So on like the highest level, I guess, actually work. So the renin-angiotensin-aldosterone system really controls their blood pressure. That's the basic way of doing it without getting down all the minutiae things that happen because of ROS. And you basically, it's probably your kidneys is the easiest way to explain. When your kidneys sense a drop in blood pressure or a drop in blood volume, that triggers off a cascade to produce the first hormone. And renin then stimulates, obviously, aldosterone to be made. And that sort of goes down that pathway where that decrease in blood pressure increases renin. Your lungs produce a propeptide called angiotensinogen. That enters into the bloodstream. You have an increase now in angiotensin 1. So the angiotensinogen gets cleaved into angiotensin 1. And then you have a converting enzyme called ACE. So you have a class of medications which are ACE inhibitors. So they stop the conversion of angiotensin 1 to angiotensin 2. When angiotensin 2 rises, it effectively constricts our blood vessels by interacting with one of two receptors. That basically can lead to a couple of different things. So all of a sudden you are now in an environment of the kidneys where you're holding more potassium. So when the kidneys take in more potassium into the extracellular space, sodium has to follow with it. That will effectively increase aldosterone. Aldosterone picks up. Now you've got increased sodium retention. So aldosterone tells the kidney to reabsorb sodium. So now you're effectively driving more sodium into the extracellular fluid, bringing water with it and expanding blood volume. And eventually you've got sort of the combination of the increase in blood volume and a decrease, obviously, in the sort of arterial size of vasoconstriction to bring your blood pressure back up again. And that's it in a very simple, hopefully easy to follow way.
Yeah, no, that was a great way to explain it. So if we talk about then, you mentioned earlier hematocrit, blood volume increase and these things. So with androgens, most likely DHTs, probably 19 NORs as well. Do you want to get into that? So what we're seeing with that?
Yeah, so obviously we know androgens with the androgen receptor, one of them is within our kidneys. The kidney androgen receptor getting stimulated produces EPO. So EPO now heads to the spleen and basically undergoes erythropoiesis. So you now start producing more RBCs. I guess the biggest recipe for disaster is you pump out a lot of RBCs and now you've got high, I guess, serum iron. So now that iron is also now starting to dump itself into these new RBCs to effectively raise your hemoglobin level alongside a higher level of red blood cells in hematocrit.
And you
so
see
the hematocrit,
low ferritin as well, right?
Yeah.
Okay.
You do. So your storage form of iron within the liver drops. The thing there is now you've got a high RBC count that has a lot of iron stored in it potentially, and your blood viscosity effectively changes now. So where there should be 50% red blood cells and 50% sort of serum white blood cells, plasma, you're now heading towards 55, 57, 58. I don't know what's the cutoff in the US. I think it's actually lower than here, but over here, the reference range is now sitting at, I think, 57 or 58. It's quite scary.
Yeah, 52 is usually where
I would. Like anything for me between 50 to 52. 52, I'll let slide that you could be dehydrated. If you don't hydrate the morning of your blood work, you can get a falsely high hematocrit because of it's measuring fluid volume.
Yeah, that's an interesting point I'll make. So when we get labs in the US, at least, they recommend that you're fasted because what they're looking, a lot of times they're looking at triglycerides. And if you're eating a standard American diet, you're going to falsely or just elevate these triglycerides in your blood. So they want to get a more baseline reading without it being skewed. But people associate the term fasting with dehydrated as well, as if you're getting surgery because they're worrying about aspiration. You should be drinking plenty of fluid before you get your labs done because it'll do exactly that. And it'll skew your hematocrit. And then, doctors
and
will
you
then
get someone, jump at the gun that something's gone wrong here, or start doing investigations towards kidney function or even checking blood pressure. So it's definitely simple thing is I always say, just try and make sure you drink between a liter to a liter and a half of fluid. If it's morning time blood works or get up early, make sure you drink your fluid before you go in so that you've actually replaced the fluid you've probably lost through respiration at night.
Yeah, we see a funny or an interesting thing, not funny. If you see in the United States is the biggest day for heart attacks is Monday morning because people are stressed about going back to work. And in the morning, men's blood is thicker, right? They're dehydrated. And the first thing they drink is probably coffee if they have anything.
Yeah. And they're getting further dehydrated.
Yeah.
So we see that as sort of one thing that obviously slowly over time we've moved away from the likes of boldenone being like the main anabolic, which was sort of the chosen of the 90s, where it was, test boldenone, nandrolone as your sort of three. And then you might find some guys were using primo, but tend to be those four that were sort of in favor for bulking. That boldenone, because of effectively equipoise, was designing horses effectively to cause what we're talking here, to improve EPO production of the horse, to increase stamina of a racing horse, basically. So,
and I don't know if you were aware, boldenone was actually discovered as it's actually a hormone that occurs naturally in those animals.
Yeah,
in cattle as well. So that's a very recent discovery. So it makes sense it actually works better in those animals than it does in humans. It has a more desired effect.
Rather than walking around with a thick, oily sludge in your arteries.
That's also why the dosing, if you look at the dosing for a horse, it's significantly less than what a human would use to get there, much larger than a person, because they can deal with that chemical much better. So, so that would be the second mechanism here that we're seeing, right?
Correct.
What was the third?
So the way I view it is hydration's always at the top. Then you've sort of got your hematocrit or red blood cells underneath. The other one is arterial efficiency. So one of the things that guys don't view is your arterial or endothelial wall is surrounded by smooth muscle. So your arteries have to be trained the same as your muscles. So if you're not doing, this is sort of where people are like, oh, I do my cardio, I go for like 30, 40-minute walks a day. That's not going to sort of cut it in terms of ensuring that this smooth muscle retains its elasticity. That's sort of the term of stiff arteries came from. So, you know, guys should try and do it. I know we're all guilty of not doing it, but at least one session of like high intensity cardio where you're doing zone 3 or zone 4 cardio to allow your body to adapt to that sort of hormetic stress where you're training that vascular system to have to operate underneath that high load. Something as simple as when someone does have elevated blood pressure is telling them to do these simple pillars of hydration, high intensity cardio, sleep, like sleep apnea driving RBCs up as well. Playing into all these sort of really basic mechanisms to start, right? Like regardless of whether they're an androgen user or not. And then if you do have this genetic susceptibility to angiotensin converting enzyme or angiotensin 2 production, then we consider how do we implement this pharmacology to intervene. One post I made on Instagram was medications were designed to reduce risk of the disease outcome, not to eliminate the biological process. So when you take a blood pressure medication, you're lowering your blood pressure, obviously, but the main things that carry from taking it is a reduced risk of cerebral vascular hemorrhage, so you're stopping someone from having a stroke, myocardial infarction, like a heart attack, because of, again, less blood pressure, so the heart is working at a more optimal pace. Renal and eye conditions, so these are the main risks that sort of reduce from lowering blood pressure. But with all this, if you are taking something like this prophylactically, where you're taking something to block ACE, or you're taking an angiotensin receptor blocker, or even a calcium channel blocker, which plays off that hydration that we were talking about with shuttling calcium in and out of the cell, you're getting ahead of the curve of prophylactically implementing something that might not be necessarily needed based off a level of what I consider abstract science when we actually look at the clinical trials of risk reduction with angiotensin receptor blockers.
Yes.
So when we look at the reduction, and they've done a very nice clinical trial on ARB use reducing hepatocarcinoma risk. So the outcome of using these things, which are purported, so ARBs are sort of purported to be anti-apoptotic, which again plays over into lowering proliferation of smooth muscle and everything like this. So these are all these mechanisms that we think play off when you have elevated angiotensin 2. They saw no change in risk reduction in these people with cancer with these drugs versus normal people. So yes, you have to take things with a bit of a pinch of salt, but really creating this statement that these are going to be saviors from an abstract point of view doesn't really make sense. From a very simple level, or not even like to make the argument, if your blood pressure doesn't go up, when you take androgens, you're not making enough angiotensin 2 globally. So there's no reason why an ARB would be used, because naturally angiotensin 2 has been designed to raise blood pressure. So if your blood pressure readings, when you start using androgens, whether now for the first time or as a sort of seasoned user, if your blood pressure stays all the time at like normal tense of 115 over 20, 115 to 120 over 80, and stays there during the duration of your cycle, there's nothing damaging about angiotensin 2 happening in the background, because the primary biological process of angiotensin 2 hasn't occurred. So all of this proliferation of smooth muscle, pro-apoptotic, pro-fibrotic effects of angiotensin 2, in my view, couldn't happen without blood pressure going up.
Yes. And we're bringing this up because people are using things like telmisartan prophylactically now, right?
Yeah. And it's not to say that you can't use these things, but use them appropriately. So yes, if you start androgens and your blood pressure before you use androgens was 115, and now you're heading for what is the new pre-hypertensive range. So once you go above 120, 125, you are now considered pre-hypertensive. Before it was actually between 130 and 140.
Yeah.
So you've actually brought it down. Then before even the A or B, you need to take a step back and go, okay, now I'm on androgens. Am I making more EPO? How's my hydration? How's my cardiovascular health? How's my sleep? All of these pillars, if you use the A or B and your blood pressure comes down, naturally you're going to see a small reduction in blood pressure from blocking angiotensin 2 on its receptor. But the other pillars then get ignored because, oh, I'm taking a medication for high blood pressure, so why should I pay attention to the basic sort of foundational pillars that drive blood pressure also? So it's not to say that no one should consider using these things. It's that use them in the appropriate situation, that if you require it, then of course, if you have familial hypertension, so it runs in your family, and you use androgens, which we know increases the AT1R receptor. So this is the bad receptor that angiotensin 2 acts on. If it increases the expression of those receptors, so the more androgens you have, the more these receptors get made. If you start making more angiotensin 2 and they act on all these increased receptors, then yes, you're going to have vasoconstriction.
Of course.
But if blood pressure doesn't move, there is no lowest dose of an A or B to use ever prophylactically, because the simple biology never occurred in the first place.
Yeah. And I think that it's being used, that's because it's being used on the black market, right? It's being prescribed without a doctor looking at these things to actually advise bodybuilders on how to use them. And they're not managing other aspects that they're using it to supplement against, or things like estrogen, right? So they won't use anything to control estrogen, and they'll let the water from that increase blood pressure, and then they'll try to use too much to manage that problem.
I mean, the other straw man that comes out of these arguments is, well, we're all using underground steroid, so now we're using underground medications. What's the difference? There is no difference to speak, but the problem here, like I said, is then it becomes almost indoctrination of, you take androgen, so as a consequence, I have to take this blood pressure medication. And it's not to pull away from the beauty of these medications and how they work. It's saying these medications have a purpose. Here's the underlying biology, which again, the very simple argument is, if your blood pressure hasn't gone up on cycle, angiotensin 2 is not your enemy.
Yeah. So why
the other side, yeah, why are we doing it? But also, don't jump the gun. So as soon as you start to see a 5 or 6 point increase in your systolic, assess your hydration. Assess all these basic pillars first. Easy wins, and then implement the medication as to speak. Like, I guess the other side of it is that we tend to associate, or it is associated, that angiotensin 2 could increase oxidative stress because of these pro-apoptotic factors that it can lead to. But then the other line side to that is, if you're only managing oxidative stress through this prophylactic use of telmisartan, or even metformin, to throw another one in that's thrown in here, where's the underlying attention paid to like polyphenol intake, what we spoke about before, vitamin C, vitamin E, vitamin A, vitamin D, all these basic pillars? Like, you'll get guys who will do junk sort of bulking and think because they're taking telmisartan and metformin that they're offsetting oxidative stress. We really need to get back to the very basics of nutrition, basics of health, basics of biochemistry. And then, yes, we've done amazing work pharmacologically to come up with this very simple solution to a genetic problem. And like, when we look at medications to speak, blood pressure medications are probably the only marvel in my eyes as humans where we've actually taken a genetic problem and actually fixed it, in that when you have a genetic problem with ACE expression or angiotensin 2 production, you can't do lifestyle intervention where your body is genetically turning out this enzyme at a higher rate. So you have to intervene in stopping its production. Other things, lipid production, unless it's like familial hypercholesteremia, you can try and intervene a little bit with nutrition, offsetting oxidative stress through polyphenols, antioxidants, whatever. Blood pressure is the only thing genetically that we have come up with a beautiful solution to address if you're susceptible to it genetically.
Yes, but it should not be used prophylactically, is the point.
In my view, no.
Yeah,
I don't even think
that's why we started this conversation.
I don't even think there's like a lowest minimum effective dose discussion here for this. You're either normotensive or you're not. And if you're not, assess the root cause first. And if it does become angiotensin 2 is your driver of that disease process, then yes, intervene. Otherwise, go back to basics. Go back to the hydration aspect, like you said, 4,700 milligrams of potassium. If you're just eating chicken and rice all day, you've got no vegetables, so you've got pretty much no sources of potassium other than maybe a small amount in chicken. So you are going to be in a heavily sodium laden position. So I guess moving forward, then it makes sense. Then let's add in a potassium-based supplement, and like that's what we were talking about when I formulated Electrolyte Plus for our company. It made no sense that all other competitors were like doing sodium chloride supplements because you weren't sodium deficient. No. So there's 4 times as much potassium as sodium in our electrolyte because I know full well that guys aren't getting enough potassium.
Correct. Yeah, but that's part of this social media myth, right? And it goes with the use of the telmisartan is that everyone should be drinking salt water, taking blood pressure medicine, right, and never taking vitamins.
And then the other side of it is when you're on prep, there's no sodium in it. Put as much sodium on your food because it'll keep you full with your low carb diet.
Right. It's when I believe you and I are on the same page where oxidative stress is probably the biggest enemy, right? Especially for a bodybuilder because you're already loading that up.
Absolutely. I mean, there's not to say that, yes, angiotensin 2 is an oxidant. Like it clearly, we can clearly see that it acts as an oxidant, but so is iron, so is blood glucose. So are half the things you're breathing in from the air. Like
and ingesting.
It's focusing on one enemy when there's a whole army of them is silly. So there's nothing here to say like publicly on a podcast that there's no problem with using blood pressure medication. There's never a point where I've said never not to use them. Right. It's use the right medication for the right purpose at the right time. And you'll see that in even like conventional medicine, they won't address a problem until it becomes a problem, which in certain cases can be a poor way of thinking. But it can also be a very intelligent way that if something's not broke, don't fix it. Yes. So there's arguments to both sides that, okay, yes, you're if you are genetically prone to angiotensin 2 and you're not under the guise of a physician, then yes, consider these medications because they will offset disease risk. This is what we try and get back to: offset disease risk, not offset disease. You're reducing your risk of all these side effects as opposed to reducing the actual, I guess, disease process itself. These are an option for you to consider, but they shouldn't be your first line of consideration, no matter what way it's put forward to you.
Correct. Cool. Well, I think that was really great. Something I would love to discuss with you in our next video is magnesium while we're on this stuff.
Yeah.
And some of the uses there. We mentioned briefly in our first video with Trenbolone.
Yeah. I mean,
and I think that we could do, if you want to do another video on magnesium deficiencies and all the things it does with mental health and all of those things, it would be really cool while we're on
I mean, it's aside from looking at even potassium, magnesium is the one that is completely oversought. And if you ask guys, well, like, what's your magnesium intake? They'll say, oh, I take 2 capsules of magnesium bisglycinate before bed. And when you actually ask about the nutrition, the general recommendation when you look at a lot of research, they recommend between 8 to 10 milligrams per kilogram body weight magnesium. And that's all driven off your ALP enzyme. And I won't pull us away in that tangent to this podcast, but with magnesium intake, for someone who is 100 kilos or 220 pounds, that's 1,000 milligrams of elemental magnesium, not 1,000 milligrams of magnesium bisglycinate.
Yeah,
1,000 milligrams of magnesium, the actual element itself. That when you look at how much is in food, 100, I think 100 grams of spinach, that'd probably be like a full bag of unwilted spinach, has 87 milligrams of magnesium in it. Like there's no way you're going to achieve your magnesium intake as an athlete through food. And that's where
not at that body weight.
That's where supplements, like even the Electrolyte Plus product I made, there's 150 milligrams of magnesium in that, specifically knowing that if you take 2 or 3 servings of this during the day with your fluid intake, you've already made up nearly half of your electrolyte intake for magnesium. Like you're sitting at 450. If you weigh 220 pounds, you're pretty much halfway there. You make up of it with food, and then maybe 2 or 3 capsules of magnesium bisglycinate or threonate, whichever one you feel suits you best before bed, and that's you sorted. And you see magic happen when you start hitting proper magnesium intake. You see magic happen. It defies, like, your neurochemistry completely changes, blood volume changes, because magnesium and calcium are the two that we didn't really talk about, but they're just as important for controlling how our effectively our serum holds an electrostatic charge.
Yep.
It's to get into it, like, I guess with RAS, calcium and the calcium channel blockers, like calcium facilitates how membranes permeability happens. So you're effectively influencing that with a calcium channel blocker. So with something as simple as calcium, guys might not be eating a lot of dairy. They might have dairy intolerances, and they're not hitting, that sort of recommended 1,000 milligrams of calcium per day. That later on in life that catches up, where they have stress fractures. We see all the time with guys with stress fractures,
heart function.
Yep. And
if you're eating nothing but meat and rice, again, where are you getting calcium from?
Exactly. We're really talking like too simple here. That I feel that in today's age, unless you have some sort of selling point to pull people to you, when you talk common sense, it's sort of like, where is the intricacy, or where is the real level of, like, I guess, making it so nuanced that it's not accessible to someone else, that you have a secret that others don't, that the basics just, unless you can overcomplicate something, then you've got no selling point. So, yeah.
Exactly. Cool. Well, it's always great talking to you. And thank you again for coming on.
A pleasure. Thanks for having me on.
Thank you.